Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites and our monthly edition of Show Me the Science. I love this show. This is like the best. October is Breast Cancer Awareness Month, and today we're asking which breast cancer patients might need proton beam therapy. Now, we've talked a lot about proton beam therapy on this show because it's new to our cancer center and it's relatively new to the field of cancer and medical oncology and radiation oncology. It is a different form of radiation for certain kinds of cancer, and it may be superior for things like some types of head and neck tumors. But for breast cancer, the more traditional photon radiation, or the more traditional radiation, is still the standard of care. We're going to talk about what that means. We don't want to confuse the audience too much. We're going to talk about the two differences and what are the key differences between those therapies, and when does proton and when does photon make better sense. Joining me today are Dr. Shane Stecklein, a radiation oncologist with our cancer center who focuses specifically on breast cancer. He's also the co-chair of the Breast Cancer Disease Working Group. And Dr. Kenny Guida, a medical physicist. We're going to talk about what they do in just a moment. He's also the director of the Treatment Planning Services and assistant director of Proton Physics. All right, guys, we're going to start with the description of what the difference is between a photon and a proton. Now, Dr. Guida, because I watch Star Trek, I understand these differences, but I'm not sure all of our audience follows, James T. Kirk or Discovery or Strange New World. So help us understand what protons and photons can do and how they're different, what protons can stop that photons cannot.
Yeah, that's a great question.
And also, explain what the heck a medical physicist does.
I'll talk about protons and photons first, and then I'll get into medical physicists. But one of the key differences is that protons have a finite range. So they can penetrate a little bit deeper into tissue depending on how much energy they have. And once they release all their energy, they stop. And we call this phenomenon the Bragg peak. So
at what peak?
The Bragg peak.
The Bragg peak, like I'm bragging about that.
Exactly.
That's pretty cool. I like
so
the Bragg
with protons, we get to brag about how we can stop on a dime. And we want to at least put this Bragg peak within the tumor cells and depart most of the energy in that area, so we can spare all the normal tissue beyond that point. So beyond the Bragg peak, there's no energy released. So we can,
and you can make sure the protons do that because they don't live very long, right? They got a pretty short life.
Well,
or the protons, right?
Well, we're not talking about radioactivity in this sense. We're not like radioactive materials like brachytherapy.
Okay, got it.
So we're able to focus this really tight beam in a specific area. And we want to put these spots within the tumor cells themselves.
So they work by the energy they have, not necessarily the radiation they have.
Exactly. So we can straggle the energy, and we can assume that we put all the spots and the Bragg peaks, align them within our target, and we can spare all the normal tissue around it and behind it as well, which is something we can't do with photons.
That's pretty cool. So what you're really saying is, when proton, you be bragging them.
Exactly.
Okay, I like that. So how do photons work then?
So photons still work in a similar manner, is that they're going to travel through a tissue, and they're going to keep traveling, and they're going to depart some of their energy on some electrons, maybe some neutrons and photons that they're passing through, and then that will depart energy within the tissue itself. But the problem is with photons, they keep traveling, where protons, they have a range based on how much energy they have.
So you charge up the protons, they expend their energy kind of in the area you want it to. The photons are a little less agreeable. They kind of have their mind of their own.
Exactly. So we have to kind of come in with more angles with photon beams, where we might rotate a whole arc 360 degrees around a patient in order to come in from different angles and really spread out that dose. Where protons, we're coming in with maybe 2 to 4 beams for some of these patients, and there's a lot less integral dose for that patient. We can really spare a lot of the normal tissues where we can't do that with photons.
That's the most sense anybody's ever made when they try to explain this to me. So tell me, is this what medical physicists do all around? They sit around trying to figure out how to explain this to people.
So part of our deal is education. That's something that we kind of get into, that we want to educate our fellow coworkers, whether it's physicians, dosimetrists, therapists, and the general public. But also there's a lot of quality assurance that goes into our jobs, making sure that the treatment plans that are devised by our dosimetrists are going to be deliverable and that they're meeting the goals of the physicians. And then we want to also just make sure that all the parameters within these plans are correct. And then we'll also do quality assurance to make sure that what was predicted is actually what we're measuring on the machine, make sure our machines are up to date to the latest specs and make sure that all of our patients are treated safely.
So you're charging the protons?
I am second in command.
Yeah. And when you charge those protons, that means that's part of all the calculations you guys are doing, so you can then brag about it. Is that pretty much the story I'm hearing?
I think you got it there.
All right, I got this nailed down. I think I could go become a physicist. No, I couldn't. All right. Well, Dr. Stecklein, you brought some images comparing photons and protons. Walk us through what we're seeing here, and then kind of along the way, tell us why, since we can be bragging about the protons, we shouldn't be bragging about them all the time, and why sometimes we have to use photons instead of a
Sure.
proton.
So as you indicated,
somebody have given us a different name because they sound so much alike, I get myself confused. Go ahead.
So you mentioned that as of now, photons are felt to be the standard of care for most breast cancer patients, and we don't have a strong body of data at this point to say that a lot of breast cancer patients will benefit from protons, but there are certain instances where they can be remarkably helpful. But those situations are pretty unique. So I brought 3 patients that I've recently treated with proton therapy to try and illustrate a couple of these situations.
Okay, I'm just going to say to our audience, by the way, this part is going to be cool, so make sure you pay attention to this. Turn your cameras on, watch this, because this is cool.
So this is a young woman who has a genetic mutation that puts her has a condition called Li-Fraumeni syndrome, which puts her at risk for a number of different cancers. She's very young, but this was already her 4th cancer. She had a locally advanced left breast cancer. And this is a patient who, if she had a stage 1 breast cancer and had the option of just doing a lumpectomy or a mastectomy, I would have said you should do a mastectomy and avoid radiation altogether, because she's also at higher risk of radiation-induced cancers compared to the average patient. And so there was really no medically appropriate way to avoid radiation therapy, so we have to do everything we possibly can to reduce unnecessary radiation to tissues that don't need to be radiated. And so what I'm showing here is a comparative plan. The proton plan is on the top, the photon or conventional radiation plan is on the bottom. And you can see here that really what I want to draw your attention to is this white dose bath here. You can see in the photon plan.
You're going to have to describe what a white dose
Sure.
is.
So each of these colored lines here represent, they're what we call an isodose line. So if you think about it like a weather map where you see those lines, meaning every point along that line has the same pressure, every point along each of those colors has the same dose.
So everything's kind of, when you see that white line or the green line, everything's getting a little bit of radiation there.
Everything's getting, in this case, a lot of radiation. So the yellow line in this case is the 98% isodose line. That means I'm giving that everything that is on or within that is getting 98% or more of the dose that I want to give to that. The lower isodose line, so this white line here is the 20% isodose line. So everything in there is getting 20% or above. I want to really limit that low dose spray to all of the tissues that don't need to be radiated because of her risk of secondary cancer.
What's the fuchsia and the green stuff?
So those are contours. Those are structures that we define. So we don't want to radiate the lung. We don't want to radiate the heart. We don't want to radiate the trachea, the esophagus, all of these normal tissues.
You still radiate the lung. You got to talk to lung guys like me,
correct.
And that's never a good conversation.
But what you can really see in this particular case, this white isodose line here in the photon plan, you're getting this low dose radiation spray over a big portion of her body. And in a patient who has a high risk of radiation-induced cancer, that's unacceptable. And so this is a case where I can treat her breast cancer and hopefully limit her risk of radiation-induced secondary cancers.
Because you can just go to the tumor and you don't have all that other, because you'd be bragging with those protons.
Because I can stop. And you know, Dr. Guida explained it beautifully. The other way I sometimes describe this to patients is proton therapy, it's kind of like reverse 3D printing. So you take that first brag peak and you paint it to the deepest layer, and then you reduce the energy and paint the next layer, reduce the energy, paint the next layer, and you don't have this spray phenomenon that goes over the rest of the body.
Well, I think you got another couple slides, so let's see the, cool effect there.
So this is a woman I recently treated who was treated for an early stage left breast cancer about 5 or 6 years ago, and at that time they didn't treat her internal mammary lymph nodes. These are lymph nodes that sit between the ribs next to the sternum. Controversial whether to treat them or not. I tend to be a purist, and the trials that looked at lymph node radiation included them, so I tend to radiate them. That's that structure that has this orange kind of circle. Those are where the internal mammary lymph nodes sit. They didn't treat them, and about 6 years later she developed an isolated recurrence in the internal mammary lymph nodes that needed to be treated with radiation. That's a very tricky spot to treat, especially in someone who's had previous radiation, because we need to, 1, avoid overlap, and 2, we need to avoid radiating the heart.
Yeah, that's always bad when you radiate the heart, I
think.
Is. Yeah, it gets this restrictive kind of period. Your heart can't do its job very well, can't expand, bad news. So yeah, I can see why you want to avoid that.
So exactly same picture. You can see how much more radiation dose is going to the heart, and particularly the left ventricle and the left anterior descending artery, which is the main artery that kind kind of is involved in heart attacks for most
So
patients.
you get a very narrow band of that radiation release energy right in the tumor as opposed to a lot of other places.
Correct.
So why wouldn't you just use it all? Oh, you got one more cool slide.
So this is the other group of diseases I treat are lymphomas. And so this is a young woman who had a bulky Hodgkin lymphoma involving her mediastinum. And we've known for decades and decades of using radiation in Hodgkin's disease that there's a high risk of secondary breast cancer, particularly in young women who are treated. And here, again, you can see that I was able to dramatically limit the dose to her breasts. Again, this white isodose line, these are the breasts, right breast and left breast. And in reducing the volume of breast that receives any radiation, I can reduce her risk of secondary breast cancer. So it's not a breast cancer patient, but I can still...
You don't want to convert her into a breast cancer
That's
patient.
exactly correct.
So why isn't Proton always right?
So the part of it is we don't have the data to show that necessarily it's better in many clinical instances. That can limit insurance approval. It can limit the ability to offer this to certain patients. The other is that protons are a little more finicky than conventional radiation. Conventional radiation.
We talked about this finickiness, but she was bragging a minute ago.
Yeah.
Now you're telling me he's finicky.
They're very, very powerful, but there are some nuances in how you give proton therapy, and done incorrectly, it can actually increase the risk of late toxicity. It can be, in a sense, dangerous if you don't know exactly what you're doing.
You gotta know what you're doing with
Correct.
it. I take it he knows what he's doing.
He does know what he's doing.
Okay,
yeah.
well that's good. Yeah. I kind of guessed that the way you talk.
And there's some data that actually the acute side effect of protons can actually be worse than conventional radiation. So that sunburn reaction we think about when we do breast cancer radiation actually is a little worse with protons. So it's not a magic bullet. I think it's a tool that we can use in appropriate circumstances for patients when it's indicated.
But if someone else was to come in with breast cancer, oh, we need to do radiation, but why wouldn't you just choose Proton for that one as opposed to Photon when normally you would pick Photon? Is it just data driven? What is that?
It's data driven, and really conventional radiation for early stage breast cancer is remarkably effective, and we can often use something called 3D conformal radiation that doesn't give that spray of radiation dose. The breast is an organ that sits mostly outside of the major body cavities, so just using clever geometry we can actually avoid a lot of those structures.
So what this sounds like is clinical decision making, trying to make sure you do the right thing and individualize it to each patient because they have different risks and different needs. Now there's a randomized pragmatic clinical trial still underway called RADComp. That sounds like a movie. Some patients are getting Photon, others are getting protons. Not going to publish the results until next year at the earliest, and when we study radiation, the science has to be long-term. Dr. Stuckline, help us understand why it's important to follow patients for years or even decades to fully understand the results of the trial.
So RADComp, it will probably finish accrual next year. We actually don't expect the final report until the mid-2030s. And that illustrates your point that we have to follow these patients for a long time.
And then everything will change.
Correct. And I think the reason for that twofold. One, we are remarkably effective with radiation at reducing risk of local regional recurrence. So our rates of recurrence in the breast or chest wall and lymph nodes are already extremely low. And then those long-term side effects that we worry about, things like heart damage, secondary cancers, they take 10, 15, 20 years for those risks to become meaningful. So we need a lot of patients, and we have to follow them for a very long period of time to see any differences.
Okay. Dr. Guida, as you look at that whole story, where does your heart lie? More protonish or more photonish?
I mean, my heart lies with the patient. Obviously, I want what's best for all of our patients. And working on both, I've worked on both sides. So I still help out on the photon side, but also now I'm working more on the proton side. So if there's a case where there's a significant clinical advantage for a patient to have proton therapy, I'd really push for that patient to go that route.
That's very cool. All right, so even in scientific studies, insurance can be a hurdle. If insurance doesn't cover proton therapy for breast cancer, or do they when you have to go to bat for patients to see what happens, does that impact scientific progress? So first of all, does insurance pay for proton therapy for breast cancer?
For most patients, no. We often have to demonstrate that there's a significant clinical advantage. And so in that case, we employ our dosimetrists and our physicists, and we provide comparative plans, much like the images that I showed you, and say, look, this is what we can spare by using proton therapy. It's not going to help the majority of patients, but that's a clinical decision that we make when we see those patients. When we see a situation or an anatomical variant where protons will give them a meaningful benefit, we go to bat for them. We write appeal letters. We fight with insurance companies to try and get that.
You call it peer-to-peer. Yeah, we all get that. That's such a pleasure, isn't it? What a great thing it is.
It's very fun. It's my favorite thing to do.
Yeah, that's what I thought too. Okay. So have you seen anybody who had like a bad outcome from proton therapy, or maybe gosh, we thought it was right, but then it didn't turn out to be right?
I have not Personally, so I trained at a very high volume proton center, and some of the early experiences with protons in brain and central nervous system tumors, because they didn't understand the kind of nuances of that dose deposition that Dr. Guida described, where they stop on a dime. If you orient that kind of stop point incorrectly and you're not careful, it can actually cause a really massive deposition of energy that can cause necrosis or severe tissue damage. Okay. We learned about that pretty early in the experience with proton therapy, and now people who are versed in protons and know what they're doing, we just know to avoid those situations, and we can mitigate that risk before it reaches the patient.
So really, it's the experience being able to do it in the right hands, because it is a highly, I mean, it takes a lot of skill to do this, right? It's not something you just want to dabble in and try to do it like in a for-profit enterprise. You really want to try and make sure this is going to be helping people. There's a lot of work to be done. So we got protons, we got photons. What's going to be the neutron, or Newton? Or what's going to be the next new cool thing here? Where are we headed?
So I think within the next, maybe we'll see the next 5-10 years. Currently, we only come in at static angles with protons, but the next generation is going to be proton arcs. So we're able.
Sounds like an artistic work here. So instead of just kind of shooting straight, you're going to be moving it around a little.
So yeah. So instead of just coming in at solid angles, we'll have a arc that will go around just like our photons. And the benefit of that could be the fact that we're coming in from all these different angles. We're able to spread out where the particles stop. So they tend to have a higher relative biological effectiveness at the end of their track. Now we can actually spread this out and potentially deliver a safer treatment for our patients.
That's going to be cool. What do you think? What's the next big thing of the Newton or whatever I'm calling it?
So I'm really excited about radiopharmaceutical therapy. So these are systemic drugs that are conjugated to radiation, radioisotopes.
So when you say conjugated, they're put together with radioisotopes.
So we take some targeting homing beacon that will take the radiation to where we want it in the body, and it's conjugated to a radioisotope, so it literally carries the energy exactly where we want it.
I like that plan.
Yeah.
I'm thinking, man, you guys are sounding like Dr. McCoy here. You're closer the further we get. That's just awesome. All right, this is a pretty awesome discussion, but we're going to be here to answer some questions. I know you're going to have those. Send them in using the info on your screen. That includes the chat on YouTube or Facebook or the X platform, or emailing the Medical News Network. Let's check in with Doc Hawk. Hawkeye, COVID numbers for the week.
22 active cases, Steve. So they have climbed a little bit for the last few weeks. I think last week we were at 20, the week before that 19 or 16. So unfortunately we have seen a climb, but it hasn't been a really steep climb, and hopefully we can continue to see those low numbers or even plateau as well.
When you look at the volume of community spread, it feels like if this was going to really escalate on us, we would have seen a pretty rapid takeoff. In fairness, folks haven't all gone inside again, though. So we're going to have to see a little bit of what that dynamic works here come November, December, I think.
Yeah, no, I would agree. And hopefully, I haven't seen any recent wastewater testing results. But we know there was an article a couple weeks ago that at different parts of the country, they have seen a decrease in the amount of detectable virus in that wastewater. So hopefully that is coming to our community as well, that decreased amount in our wastewater. So that means decreased amount of spread in the community of the virus as well.
And we can cross our fingers around that one. Hey, the new COVID vaccine rollout has been a little bumpy, and that might be a conservative way of saying, what a mess.
Yeah.
Now, this is the first time the government hasn't been in charge of the rollout. Not a four-star general, not a lot of stuff going on around it. It's more like, quite frankly, how we would roll out all other vaccines. It's not special in that regard. It's been a little bumpier. When do you think we're going to get it? What's the story here?
No, I think that's right. But to your first point, we have to really kind of marvel at what Operation Warp Speed was able to do. One, with the development of the vaccines, but then two, the rollout to 330 million people. I mean, it was just amazing. Yeah, so now, like you said, the government is not taking really a role in it as much. So it is kind of, the rollout is just a little bit different. Hopefully, within the next couple weeks, we will see those supplies make it to those pharmacies and those doctors' offices. We know the supplies are scant right now, but hopefully soon people will be able to get those, especially those people at greatest risk.
I think it harkens. Remember when we first rolled out the COVID vaccine in January 21, and everybody wanted the first dose, but there really just wasn't that much dose having been made yet. I think that's kind of the story here. It feels bumpy because there's not that many doses out there yet, and so everybody's like, well, haven't we got it? Well, because it's not been made yet. Interesting, the CVS and Walgreens and other pharmacies got it first. That may be appropriate. The other challenge is that the government in the past has paid for it.
Yeah.
That's a different story this time.
Yeah, and right now, again, all these insurance companies should be paying for it. We know also that the government has that bridge program, which should allow those commercial pharmacies like Walgreens and CVS to give it to those uninsured for free as well. So there is that bridge program, luckily.
All right. Now, a pretty remarkable thing happened this week regarding the Nobel Prize winners. Doctors Drew Weissman and Katie Carrico received this year's Nobel Prize in the physiology or medicine for their foundational work in messenger RNA vaccines. Now, they first published their data. Now, this is published. That's not when they started doing the research, right? They first published their data in 2005, 15 years before the COVID pandemic. I don't think mRNA vaccines are very new, Hawk.
Yeah, no, I think that's a great point that you make. Not that they published it in 2005, but that the research was going on way before that. And I think at one point in like 1995, Dr. Carrico actually was demoted or lost her position at her university because she couldn't get funding for the research. So this has been going on quite some time. It is not new technology. The vaccine is new, yes, but the technology is built upon decades of research. So.
Yeah, and also to say, I think the FDA or the CDC yesterday gave approval to the Novavax vaccine too.
Yeah.
So if you don't want to do a messenger RNA vaccine, you want the shot, Novavax will be out there once it hits the market. So lots of different choices to have.
Yeah.
And I think the best thing you could do is have one. I know I'm going to have one as soon as I get it right here at the University of Kansas Health System on Open Mics with Dr. Stites, so we could say, open shoulder with Dr. Stites once again at Hawkeye.
You know, but I am so thankful we have that other platform for those people that, you know, still would not like to get the mRNA vaccine. But so I'm glad that the FDA gave approval to that, and hopefully that will roll out soon as well.
Yep, totally with you. Okay, Alexis Delset is watching for questions from our community. Alexis, what do you got out there?
I have a great question from Ruth Allen. Ruth wrote in on Facebook, speaking of vaccines, I just heard the new RSV vaccine will be very high priced at $300. Is that true?
That's what we're hearing, $300 to $350. And the way it's been constructed so far, only those over the age of 60 are eligible to get the vaccine. I keep hoping the CDC will reconsider. I think there are a lot of high-risk patients with severe airway disease with whom RSV is a real problem, like my lung transplant population. And so I would like to see that, but so far we're only seeing it, Hawk, in those over 60.
Yeah, and I would agree with you. I think, again, Steve, that you made that age determinant, and it's recommended only for people above 60. So I would gather most people have insurance or Medicare that should pay for it as well. I would think those government programs would pay for that vaccination.
Yeah, we just don't know that yet, and I think, but right now it is $350, I think, Alexis.
Denise has a question to follow up on the RSV. Denise wants to know, what are the possible side effects for the RSV vaccine?
Yeah, Hawk, what I'm seeing is a side effect like any other vaccine. Like I got my I did get my influenza shot yesterday, people, just to say, trying to meet all the deadlines. So, but it's the same story for almost all vaccines.
Yeah, I mean, the most reactions, again, were the local site reactions where it was injected. A little bit of discomfort, pain. Really weren't seeing the reactions of the chills, the fever, the myalgias, just feeling bad, like we did with the COVID vaccine or with if anybody's ever gotten the shingles vaccine as well. So really mild symptoms and mostly local right at the injection site.
Anyway, I think we spent a lot of time talking about some of these side effects. The reality is they're all entirely tolerable, I think, and even a little dose of a little Motrin or Tylenol will help that a lot.
Much better than getting the disease.
Yes.
Yen Liang has a question. He wants to know, can heavy particle therapy be used to treat breast cancer, and how does that differ from the proton therapy we discussed today?
Okay. Well, clearly not something I'm going to answer. Doctor,
Do you want to start off with this one?
So
talk to us about what is heavy particle therapy.
Heavy ion therapy is kind of the next step. So protons, right, they have a physical mass, they're a particle. Heavy ions, the one we have the most experience with is carbon ion therapy, and there's a facility in Japan, I think there's another one in Germany.
Yeah, Japan and Germany have pretty much all the heavy ion facilities in the world, but I think down in Florida, it might be the U.S.'s first venture in this technology.
What would be the advantage of it?
So those particles they're much more damaging. They're more massive particles than a proton. And so because of that, they can deposit much bigger packets of energy and they can be more damaging. So for things like hypoxic cancers, conventional radiation is really heavily dependent on the oxygen effect in cancer cells to damage them so that they die. We can use heavy ions and we can overcome things like hypoxia. That was the principle for using neutron therapy. I don't know if people have seen the picture of Robert Ebert, who was treated for a salivary gland cancer, really severe toxicity. It killed the cancer, but it had horrendous toxicity. I think there's still a lot that we need to learn about heavy ion therapy, but that's another thing that's coming down the pike, and maybe in a decade or two we'll be talking about heavy ions.
What's a hypoxic cancer?
So cancers, as they grow, especially rapidly growing cancers, they outgrow their blood supply. They grow too quickly and the cells start to move away from a blood vessel. The middle of that tumor tends to become low in oxygen. And so those cells have adaptations that allow them to survive in that low oxygen environment. That also tends to correlate with really aggressive behavior. Those cells have learned to survive a really hostile environment, so they have a lot of other hostile behaviors that they exhibit. It's hard to kill those cells with conventional radiation because photons, you really need oxygen present to damage the DNA.
Okay.
That's not the case with things like heavy ions or alpha particles or other what we call high linear energy transfer radiations.
And a few years ago, neutron was all the rage.
It was. I think Seattle is the only place in the US that still has a neutron therapy facility. Salivary gland cancers have been one setting where there's still some data maybe supporting that, but neutrons are even more finicky than protons, and you just have to be really careful.
All right. Alexis, we're back.
Question from Jean Reardon. Jean wants to know if you can talk about non-mRNA vaccines as any good alternatives.
Yeah, I think that's what we were talking about, the Novavax therapy for COVID, and it's a more traditional vaccine, Hawkeye, and I think very effective.
Yeah, it's just the spike protein, and it is very effective. Just as you said, older platform, we have different kinds of vaccines with this type of platform, similar to really what the RSV vaccine is, but also the hepatitis vaccines as well. So it's an older platform and technology, but it's still effective. And again, thankful that the FDA was able to review all the data and say, yes, it looks good. It will help reduce your chance of severe hospitalization, severe disease and hospitalization as well. So.
And it's based on the more Omicron derivatives as opposed to the earlier ones. And to find it, you're going to have to probably Google it. And I don't know that it's in pharmacies and other places yet. It's a little harder to find, a little harder to get. But I think, as you say, I think it's very effective, and I think it's a good vaccination for those, especially you don't want the mRNA vaccine. It's harder for Novavax to pivot than it is for the mRNAs. Now, they've done this one, though, so hats off to them.
Yeah.
I have a breast cancer question here. One of our Facebook viewers wants to know what types of breast cancer patients are most suitable for proton therapy.
So we know that breast cancer is a heterogeneous disease. There are multiple types of breast cancer, and biologically they behave differently. From a radiation perspective, it's really more about anatomy and the areas that we need to treat. So we treat a triple negative breast cancer very similar to how we treat a hormone positive breast cancer in terms of the regions we treat. So that's less of a consideration in radiation oncology as it is in, for say, medical oncology, where your treatment path could be completely different based on the biology of your cancer.
Okay.
I have a great question from Paul Slavin. We've talked about this a little bit on our program. Paul wants to know what's a rough percentage breakdown of men versus women with breast cancer and how you treat them, and how do men check themselves for breast cancer?
Well, that is a great question, and we'll delve into that for a moment.
Very good question. So 1% of breast cancers are in men. It is a disease that overwhelmingly affects women, but we do have 1% of our patients are men. Historically, from a surgical perspective, they were all treated with mastectomy. That's not the case anymore, and men can be eligible for lumpectomy, a much smaller surgery, and we really treat them much the same way that we treat women. Again, it's an anatomical decision of when we're using radiation and what areas we target. So we approach it very similar to how we approach women with breast cancer. The vast majority of male breast cancers are hormone driven. They're positive for estrogen and progesterone receptors, and we use the same types of systemic therapy and endocrine therapy or anti-hormonal therapy that we use in women.
And is the difference in the reason that you see so many in women but not so many in men, is there's just so much more breast tissue in women than men?
There's so much more breast tissue, and we know that the most common type of breast cancer, these hormone-driven breast cancers, really are a result of lifetime exposure to sex hormones, estrogen, progesterone. So
yeah.
menstrual cycles, breastfeeding, all of these things that influence the hormonal kind of environment of the breast can increase the risk of breast cancer.
And if you have like a BRCA2 mutation or a BRCA1 and you're a man, that does increase your risk of breast cancer. So at that point, you're going to have, so some of it's genetic.
It is. Surprisingly, we don't currently have good data that say we should screen those men like we do, our women who are at average risk or women who are at high risk because of genetic mutations. So we don't do routine mammography even in men who have a BRCA2 mutation.
Yeah.
I have one more question from Jill. Jill wants to know if you can talk at all about whether or not soy increases your risk of breast cancer.
Ooh, soy. Okay, I didn't know about that one. Let's go.
So that's an extremely complicated question, and I think you'll be able to find literature that supports one view or the other. So soy has a lot of phytoestrogens, or kind of estrogenic compounds in them that, again, in some situations can maybe stimulate estrogen signaling, in others can maybe antagonize it. There's a chemical in soy called genistein that people use a lot as a supplement, and there's some data that it may actually be useful as a preventative agent. But again, there are data saying that you should avoid really high intake of soy because it's just lots of extra estrogenic compounds. I think that soy is fine. I would say don't eat pounds of tofu for every meal for the rest of your life, but soy in moderation is probably totally fine.
Okay, so I have one last question on here that popped up, and I've heard it before. Some people talk about flash therapy and radiation therapy. What is flash therapy? Because when I think about flash, I think like Flash Gordon, or those people who flash themselves on football games, stuff like that. So what is flash therapy?
So flash therapy is a much higher dose rate than we currently treat for all of our radiation patients. So like normal dose rates are somewhere up to about 6 gray per minute, where flash we're treating about 40 gray or more per second. And the idea is that this ultra high dose rate actually spares normal tissue, but doesn't minimize the dose to the tumor cells. So if you can at least minimize normal tissue dose and maximize tumor dose itself, this is something that we should strive to look into. And you can do this with photons or electrons, but now we're able to do this with protons, or this is the aim for KU with their IBA Proteus 1, is to look into doing flash therapy down the road with our technology that we have here.
So, first of all, Alexis, thank you, and to these guys, I just want to say thank you. This has been a great conversation today. I want to grab your final thoughts in just a moment, but just as a comment. If you're a cancer patient, this is why you go to a comprehensive cancer cancer center, because these guys sit around, and they don't sit around, sorry, that didn't sit around, but they look at every patient as an individual, and then they put all their heads together, and you have these whole study groups and work groups, and you sit down and you talk about each patient and the approach, and there's lots of opinions being generated. How do we do this? What's the best way to go? And you heard the day on the program. There's all sorts of choices. So, of course, you want good people like Dr. Guida and Dr. Stecklein to help have input, along with all the other members of the team. That is impressive stuff, and that's how comprehensive cancer centers work. Well done, guys. All right, so final thoughts from the day, and I'm going to start with Dr. Guida today. The bragger.
I really think that Proton is a phenomenal treatment advancement that we've been able to provide our patients in the Kansas City area, Missouri, Kansas, and all the neighboring states. It really shows our potential to continue to grow in our cancer program, and really offer such an awesome technology to all of our patients that could really be beneficial for a lot of them.
Yeah, that's great. Dr. Stecklein.
So I think that multidisciplinary care matters. I think that that's what you get when you come to the University of Kansas Cancer Center, is you get expertise in breast medical oncology, breast surgery, breast radiation therapy. And then I'll echo Dr. Guida's thought that protons are a tool that we have available when it's necessary. It may not always be necessary, and that's a decision that you and your radiation oncologist will make together, but it's a tool that we can offer when it's needed.
Yeah. Dr. Hawk.
I think we've all been concerned about the vaccine rollout. Just like you said, I think we went through reasons as to maybe why, but hopefully it will be out soon. But there still are other vaccines that are available right now for you to get, including influenza vaccine, RSV vaccine if you're above 60, and hopefully soon there will be a larger, broader rollout of the COVID vaccine as well.
We talk a lot on this program about the impact of faith, hope, and science on all of our lives, and I think one thing you should take away from today: Science doesn't always give you your answer. It doesn't give you all the answers, right? Because the science is so dynamic. We have to keep studying, we have to keep studying, we have to keep learning, we have to keep learning. But what it does do is it clearly helps you inform your answer. And you listen to these great folks up here talking today, you realize how much they've studied and devoted their lives to trying to help find the right answer for their patients. So you can go find people who do this for their entire life and they focus on it, or you can go to the internet and just find what some people happen to throw out there. I think the most important impact of science, and the reason it's so important, is that it helps inform us on the right thing to do. The right thing is defined by our own personal choice. But ultimately, science helps inform that in a meaningful and impactful way so that you can live your best life. So thanks everyone for watching and listening. And remember, faith, hope, and science, that's what we like to show you the science. We'll see you soon.
Exercise is medicine, even if you have cancer. I'm Alexis Del Cid on the next All Things Heart. It was a passion that doctors say helped save a cancer patient's life. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.